I'm Al McFarlane. Welcome to Conversations with Al McFarlane. Glad to be here and glad to have you along as well. Today is Tuesday, May 17th, 2022. It's a beautiful day. Pleased to have a great program. My first guest on the program is Dr. Brooke Cunningham. She's newly appointed Assistant Commissioner at the Minnesota Health Department. She's got a major mission in the area, the field of equity, among other things. Dr. Brooke, good afternoon. Welcome. Good to see you.
Good afternoon.
Well, we talked before, I believe, early on in this series, but you weren't yet commissioner. Congratulations on your appointment.
Thank you.
And let me start just by asking you to talk about your role as an assistant commissioner in a new initiative
Yes.
in the health department.
Yes. Mr. McFarlane, I'm going to also take a moment to share a little bit about my background, if that's okay. But
please, yeah.
Okay. So
that was question number 2, but you can go ahead.
Oh, that was question number 2. Well, let me start with question number 1. So I am the new assistant commissioner for health equity at the Minnesota Department of Health. Right. The Department of Health has Jan Malcolm as its lead for our Commissioner of Health. Mm-hmm. And then it has several bureaus under Commissioner Malcolm. While the department has had a long-standing interest in equity, now moving it into a bureau structure really is going to amplify and strengthen the ways that the Department of Health advances equity, both by promoting all of the work that sort of the preceding center, which is still in the Bureau, has done, the Center for Health Equity, but also working very closely with Commissioner Malcolm, as well as the other commissioners in their spheres in terms of health protection, health improvement, and our Health Systems Bureau to really bring home equity in all of our work.
And so what does this opportunity mean to you personally? Why is it important that the Bureau is created, the work is identified, and that you're in charge of it?
So, and here is where I will lift up my background. So I am originally from Richmond, Virginia. For folk who are listening, I am a Black woman, right, who grew up in the capital of the Confederacy. And went to Monticello and Jamestown like every year in elementary school, but sort of began to notice how race structured life in Richmond, Virginia, right? And was such a part of our history that was often unspoken, right, as an elementary student. And so I started picking up on those things very early on. Fast forward, I ended up going to medical school only after I learned that I could become a sociologist, because that piece of me that had noticed, again, since elementary school, since 6th grade, how race structured the landscape. It structured access to resources, structured opportunity, structured who was in my, advanced reading group, right? Structured what the middle school looked like, right? All of the white kids ended up being in the advanced area in middle school, right? Tracking. So all of these things that I noticed. So I became a sociologist because looking around me, and again, being in Richmond, Virginia at that time, there was a lot of gun violence. Gun violence remains a problem, as we all know. But at that time, and I really thought doctors didn't really care, right? They just waited for people to show up at the doorstep of the hospital and get paid, right? And they were not as actively involved in addressing the real core roots of poor health, poor outcomes. And so I only became a doctor after I found out I could also be a sociologist, and move all of that fast forward. Have been a primary care doc, working when I came to Minnesota in 2013, joined the University of Minnesota in 2014, but working in a space to really look at health system inertia around health equity. And again, to make things short, the opportunity to come to the health department as a key stakeholder in advancing the health of all Minnesotans is really my opportunity to, I believe, have greater impact personally in achieving health equity for Minnesotans. I think it's great to do research, but the research basically outlays over and over again what we know about how social and health outcomes are patterned. And what we need is action and political will to do something about that. So to the extent that I can be a voice, I think having some of the credentials is helpful in these is to really be a voice, to bring equity into the conversations, to ask the tough questions, to partner, right? And so one of the grants that we have is called Community Solutions. And Mr. McFarlane, you have heard me say, that I really do believe that community input equals community impact. Mm-hmm. And so how do we routinize that and make that what MDH does in the service of the health of all Minnesotans?
I'm Al McFarlane. This is Conversations with Al McFarlane. My guest is Dr. Brooke Cunningham. She's Assistant Commissioner at the Minnesota Department of Health. Let me give you some more background from the website at the Department of Health. Dr. Cunningham, as she said, is a general internist, sociologist, and assistant professor in the Department of Family Medicine and Community Health at the University of Minnesota. Prior to joining MDH, her research focused on developing strategies to reduce racial disparities in health, including addressing the adverse impacts of exposure to racism. She also co-directed the University of Minnesota Medical School's Diversity, Equity, and Inclusion Thread in Medical Education. In 2021, she was selected as one of the 4 inaugural recipients of the University of Minnesota's Justice, Equity, Diversity, and Inclusion JEDI Award. She's also a primary care provider, she was anyway, at Community University Healthcare Clinic, which was a federally qualified health clinic in Minneapolis that serves a diverse patient population. Right here near KFAI on the West Bank, I believe it's still there. Is that correct, Doctor?
So it's over there at the corner of Bloomington and Franklin.
Over south now. Okay, great. I've been there. I'm just going to remember your background, as you mentioned. You've got the doctorate in medicine and a doctorate in sociology from University of Pennsylvania, but you also have bachelor's degrees in history and African American studies from University of Virginia. I call those impeccable credentials, and it makes you, I think, an awesome and I think, fierce leader and investigator and advocate, grounded in a knowledge that many of us say has been hidden, that many of us, however, have undertaken an earnest pursuit to uncover the foundations of the disparities we experience and to make ourselves and our energy, our work, part of undoing that which is unnecessary and destructive to our humanity and therefore to society. So given that background, how does that training kind of drive you, influence you, give you more insight, more energy to pursue the mission as you've defined it and described it?
Right. No, thank you. So what has motivated me, particularly sharing my background with you all, is really thinking about health, right? Not from what is happening in the body, mm-hmm. as much as the factors that are acting upon the body, right? In terms of, Robert Wood Johnson likes to say, the environments in which we live, work, and play. But mm-hmm. it's even more than the things that meet our eye. It's the little interactions, right, that happen on a day-to-day basis that that create stress for people. It's the things that people of color in particular, now we probably all are hurt by the violence directed mm-hmm. at people of color. But if you are a member of one of those groups and people, and there's a rise in white supremacy, right? And there's a targeting, ongoing and more explicit. There's been a targeting throughout our history, but the revival that we are seeing in terms of racist violent incidents. And so even just that witnessing is harmful to your health, right? Not to mention the everyday experiences for many people on the job or worried about their kids, right? And then talking about sort of the neighborhood factors, right, that come into place in terms of, can we get a quality education so that people have quality employment opportunities, right, to make a living, to care for their family. And so that we live in a context and with a healthy context to facilitate healthy behaviors and decision making. And so I am driven from, again, what I saw as a little girl, right? And my knowledge of, the history, particularly of Black people in this country. And my knowledge that the circumstances under which Black people have lived have been unhealthy circumstances. And so
not as a question of choice.
Right.
Some would say we chose to live that way, and it was our either ignorance or willfulness that kept us out of quote unquote civilization, but that's all bogus.
Right. And yet there's a narrative, right? And so I will say that coming into the health department, I hope, and I've been talking to people about, what is our proactive strategy in terms of public health strategy around challenging that narrative, Mr. McFarlane, that you're talking about, right? Because that narrative informs how we fund things like public health, right? And so, and I would just say to what you were asking me at first in terms of my preparation, I think I come not only with a deep love for Black people and by extension, other communities of color with their own story about their American experience, and with even our white brothers and sisters, right? And so I come from, and as a physician, I think that is core to the work as a physician. You have to have a deep sense of care for the person who is sitting in front of you, that you too want the best for them. And so I come into that with a core driver and motivation. But I think the thing about my training is that I speak the language of the folk who sit often in powerful spaces, who like that quantitative data, and I can speak the quantitative, and I can tell you where the data is missing and what the data doesn't tell us, and what more we can get from the data with new approaches and different approaches, right? And so I speak that language. I also have historically been a qualitative researcher as well, and so and this gets to the limitations of data, right? Because data is a number on a page that can be interpreted one way or another. And Mr. McFarlane, as you say, people got these competing narratives about what that data means. And so I also, again, love to be connected to people. And that's why I did qualitative work. But here, people can tell us what the data means, right? If we're inclusive, if we share our data, if we invite folk in. So I think those are the aspects of my background that I would highlight about my preparation for the role. Mr. McFarlane, I think you're on mute. I can't hear you.
See it now. I didn't know how to fix that, but I have now. Thank you. But doctor, I was saying that I was going to say that our people, or that people can also tell you what's ailing them often.
Yeah.
And the question is, will they be believed?
That's
and one
right.
of the challenges in our community is a sense that we are not believed,
That's
or
right.
that our opinions, our assessments of our own feelings are of little or no consequence, and therefore we present as subjects for experimentation, and that without our own permission or knowledge or not acknowledgement or engagement. And so that's a problem. And I'm happy to hear you bring your skill, your training, and your interest in data, the power of data, but also knowledge of the limits of data and the strategies to use data. One of the things that we've been doing at Insight News is promoting data-driven decision-making in our community. And that's exactly what I think I hear you talking about as one of the ways to use data in an appropriate, scientific, ethical manner to promote healing and well-being and access and solutions for all people, but particularly those of us who've been systemically denied or disbelieved. So talk more about that.
Yeah. So I think there are a lot of data opportunities, particularly at MDH. I have already started, as I got here, I told people that I was going to be in everybody's business, right? And I said, in the introduction, everybody sort of under the sound of my voice at a town hall is on my team. But I've particularly been in the data folks, email and their business, right? Because part of my role right now is, of course, sort of thinking about COVID and thinking about the COVID data. But there is folk at MDH are already working on, quote, data modernization. And so what does that mean for health equity strategy? And so on one hand, it does mean what data are we looking at? What metrics are we collecting? With COVID, MDH has really been looking at what they're calling social vulnerability. So these zip codes, social vulnerability is actually a measure that the CDC developed and we adapted. And it really looks at things like housing density in a zip, percent minority, economic insecurity, et cetera, to classify zips as high or low on social vulnerability. So that's an example of a new thing that MDH has been doing with data since COVID. But we can continue to think about, well, what are the metrics that we need to employ beyond social vulnerability? And I think that is part of the question that I'm putting a team together to think about. What does data for equity look like? And it's not just about the measures or the metrics, right? It's about how we identify those measures or metrics. What sorts of things are we not measuring but could measure? And how do we decide that? Are we just going to talk amongst ourselves, right? And down here in St. Paul or by Zoom, right? Or Teams? Or are we going to be broader and invite people in and go out into community to talk about what are measures of health and well-being that others would like to see? And once we collect the data, are we going to be similarly broad when we invite people to interpret it and make use of the data and disseminate it? And so again, I would like as much of an inclusive strategy as possible. And at the same time, as people ask me, I can't tell you how many people want to see intersectional analysis in data, right? Meaning, every group, when we talk about these big groups, Black people, Asian people, there's a lot of diversity within the group that just relying on one metric of, for example, race alone does not give any insight into which Black people, right? Which Asian people. And so there's a lot of call for disaggregating data, and the data sources that we have currently, we have to look at what have been the challenges, because people have been calling for that for over a decade, right? And so, and it's time to get creative about moving past those challenges. So there are a lot of data opportunities, from identifying the metrics, thinking together about what those metrics mean, thinking about addressing the challenges with disaggregation, thinking about what new metrics would be beyond social vulnerability. And so I think data is critically important, to your point, because we need information, right?
Mm-hmm.
We need information, and we need to share that information, and even have bi-directional information. So the other question that has already come up is these grants that MDH does. I mentioned community solutions. There's the Eliminating Health Disparities Initiative. There's good information, good data in those grants. How does that information that community organizations and community investigators produce trickle up into how MDH designs its public health strategy? So, right, it has to be inclusive and bi-directional, and we have to figure out, and I haven't figured it out yet, but I'm sure, I invite everybody, you and others under the sound of my voice, right, to help think with me about the best ways to create those structures so that we have deep, sincere, accountable, right, data and relationships.
I'm Al McFarlane. This is Conversations with Al McFarlane. My guest is Dr. Brooke Cunningham, Assistant Commissioner, Minnesota Department of Health, and she's leading innovative work at the Department of Health. She is responsible for overseeing the Center for Health Equity, the Office of American Indian Health, the COVID-19 Health Equity Team, and Diversity, Equity, and Inclusion at the Department of Health. She is a bureau director. I looked at the org chart. I think maybe 6 different groups or bureaus inside the state agency, and she leads one. And as she said, she's in everybody's business because she's about the data. You use the word, Doctor, trickle up, getting this data to trickle up to inform policy making
Yes.
at the executive level in state government.
Right.
I raised a question about trickling out. How do we also ensure the data gets out? Part of the mission, it seems to me, and you can address this, is that we want to create more informed, properly informed, amply informed consumers, citizens, residents. And one of the big problems, the biblical story, with no knowledge, people perish. We've been perishing for lack of knowledge about health and about policy and about the data in our community. In fact, we have an aversion to the data. We've been researched to our disadvantage so often that, and in ways that are storied, that we have an aversion to participating in clinical studies and research, et cetera. So part of the mission now, Commissioner, seems to be how do we reframe or reorient or redevelop, reawaken in our people, our community, an appreciation of value, a sense of equity and ownership. Then what is your role, not yours, but the department's role in ensuring that nurturing takes place where people feel like they can grasp and understand and know their own benefit and therefore be aggressive participants in shaping policy? What do you think?
Yeah, so I'm gonna take this real upstream because I hear you, and skepticism about data, skepticism about, for example, state agencies working on behalf of, sincerely on behalf of people of color, Black people specifically, has come by honestly, right? So what I tend to say is it really does have to start with us. And when I'm saying us, I'm actually, I am actually saying us as MDH in the sense that we have to behave differently with community, because it's not about community members' mistrust. In many ways, it's about our trustworthiness, right? And so what I will say in different form is we have to. When I'm saying we, I'm speaking of myself, and I'm speaking of MDH. So, I haven't cleared this with anyone, but I really feel like we have to, what I would say is show up and show out for people of color, for American Indians, for LGBTQ plus Minnesotans, right? and it has to be consistent, and it has to be authentic. And I think, right, if you continuously show up and you know, and center on relationship and humility, then you will build a relationship in which people, where some of those barriers, I think, come down. Some of those barriers come down. And so I want to see it. And COVID is a great example. We've had more community sort of investment. From what I can tell, MDH has done that more so with COVID than perhaps in the past, right? Yeah. And so the question is, how do we deepen that? And when I say routinize it, then I look at the ways in which, so how do you do that in a system, right? How do you do that in a system? And so I look at the primary activities of the system, right? Which include, we already spoke about data. That's a primary activity of MDH. They have all of these domains, and those domains are often grant funded by the federal government. And so if we're going to do it seriously, then certain things need to be in our grants, right? Like there need to be certain line items within these grants, because that's how we work. And so I'm trying to learn where those opportunities are in MDH. And again, insert myself and ask the question about, well, we said we're serious about this. Then where is it, right? Where is it within our system? And so, and I think and I think that will fundamentally change the ways in which the public, broadly speaking, responds to our work and responds to us.
I'm Al McFarlane. This is Conversations with Al McFarlane. My guest is Dr. Brooke Cunningham, Assistant Commissioner, Minnesota Department of Health. A great conversation. I'm so glad that you're there and glad that you're here, Dr. Cunningham. I love talking with you. I'm excited about the energy that you're bringing in, this commitment that I'm hearing and seeing in your approach to the work, the seriousness with which you are undertaking, creating a Department of Health that can be the very best Department of Health for all of the residents of Minnesota. I want to take a minute to step back, and I know that you've got some more things to do. You can sort of wind down when you want to, but I'm going to keep talking as long as you can stay, okay?
All right, I can go.
Okay. But just let me know when you got to wrap it up, because I know you got a schedule.
I do. I'm going to look at it while we're talking, but I think I'm all right. Go ahead.
Okay. All right. Well, let's talk about your personal story. I was interested that you were a sociologist and historian. Yes. Let's talk history first. Okay. And what's your passion about history, African-American history? How did that lead you to your interest in being a doctor?
Oh, yeah.
Let me rephrase that.
Yes.
When Brooke was 5 years old,
yes,
what did she want to do, and who did she think she'd be in the future?
Oh, so this is the hard thing for my mom, I think. Like there came a time, I don't know if I was 5, but I remember it was at night, and I called my mother into my bedroom, and I was excited. I don't know how old I was. I was in elementary school, clearly. And I said, and I called her in because I wanted to tell her who guess what, Mom? When I grow up, I want to be president of the United States. Oh. But do you know what my mother said? In her very pragmatic Black woman, she was a first in many ways. And, she said something to me like, sadly, like she probably regrets it if I had told, but you are Black and you are a woman, right? Or a girl, And so she basically was telling me, yeah, I don't think that's going to happen in this United States of America. Okay. Now, I know if I remind her of that story, which she has probably forgotten, but what did that mean for however old I was, 7 years, however old I was, so excited. and then told because of my race
Mm-hmm.
and my gender in this country that was not going to happen. And she was telling me that to protect me. But as a child, you know, that hurts, right? Like, what? But so where, like, so then hearing that from, and I know, like, even then, even though it hurts, you know, your parent is telling you that for a reason in some ways. And then you got to understand. So what do you get? What made you curious about that's probably part of it, right? And part of me, and again, my mother was a first in her own right, and some things, right? Like, which meant I ended up growing up, both my parents, you know, some of the first in the family to go to grad school. So what did that mean? I ended up living in a predominantly white neighborhood as a young person, and trying to also understand, why does the neighborhood look like this, right? Or walking in certain parts, like, you know, the grocery store. Even I will tell you, even coming to Minnesota, somebody bring back memory, you know, people look up, oh, you're here. Yeah. Right. And so it's just sort of trying to put those pieces of the puzzle together. Why does my environment look like this? Why in my school, again, growing up in Virginia, there was busing. This probably ages me a little bit. There was busing. And so when I talk about the advanced reading circle, it was like in fourth grade, I was like, look at the racial demographic, like all the white kids were in the advanced reading circle. And me and right. And so trying to understand that. And then where did all of the Black kids go at 3:00? Right? Because they were bused. Right? To the other side. And so it's those sorts of things that I started trying to make sense of. And then again, just to my background, these are all the seeds that got planted. I went to a sort of college prep public school. And then public school, and we could talk about Brown versus the Board of Education, but schools in many places are more segregated, right?
Yep.
These days than immediately, right? Like, you know, in the 70s, right? When I was coming. And so just noticing things as a person in school, right? And then going to that magnet, well, it was what do we call a magnet high school now? Again, predominantly Black, but small college prep, but certain key people. I had some great Black teachers, right? And who actually advocated for me throughout my just again, we're talking about tracking. There's certain things in which people get tracked. And that can be by lots of things, but also by your elementary school. And so advocated for me, particularly in middle school. And then when I was in high school, you know, just the certain teachers who were very grounded in African history and culture, and held spaces for that, right? And then also culturally represented, right, in terms of their own aesthetic coming into the school system. And so there are lots of reasons why I think I developed a more critical consciousness, and it's definitely my parents and my teachers that helped with that. And then just looking at things around me as you become a teenager, right? You want a different, you know, our young people are powerful, right? And they have and when I was at it, I look back at some of the things that I wrote back then. I said, what happened to me? Right? I've been dulled over time, but
you're on fire.
So, but it was all of those things that made me do history and African American studies, right? Because because as many people, and then particularly going to the University of Virginia, again, Virginia has a particular legacy, right? In terms of one of the founding, colonies, right, in our history, and sort of confronting what is that part of our American history that that we hear about so much, and we want to celebrate, but we recognize its limitations and who it included and who it did not include, right? Or included only as 3/5, right? So just trying to understand all of that. Like, all of that is why I did history, African American studies, and did medicine, honestly, strategically, because thinking about how to have power for change, and physicians got a lot of power, actually, still today. And sort of being strategic about how I could get into a space that could have positive impact on our social well-being, because that leads to our positive health outcomes. I feel like I'm just blabbering on, but thank you for giving me
listen,
the time.
I'm loving it, and it sounds to me, Dr. Cunningham, that you have not abandoned the idea that you can be president. So
I don't know.
I'm looking at you and I'm listening to you, and I'm hearing this powerful analysis and awareness and consciousness. And I think that I see a commitment to be authentic, to be yourself. And being yourself is going to be being yourself, I think. So I don't see limits, and I see only possibilities that I think that you are continuing to explore, develop, that they all come from somewhere. So in that spirit, let me take you back further.
Okay.
What is your sense of genealogy, of lineage? I asked my guest, whose shoulders do you stand on? And I asked them specifically, talked about your grands and your great grands. Have you done genealogy? Do you have a sense of your Africanity or European or native roots? Does that matter to you? How does it show up in your life and in your practical today?
So it's interesting that you asked me that question. I mean, I'm now, I guess, 6 weeks out from my grandmother's passing, and she transitioned late March.
Okay.
And so my genealogy, as sort of my roots beyond sort of the Virginian context, I honestly don't know. Okay. But I know the stories that mostly my mother, because my grandmother was very private. Right. And so I did at one point several years ago try to interview her. Right. I'm a qualitative researcher. I do interviews. So I took the digital recorder home like one summer. And she stopped me at some point in the interview and was like, go do something else. Right. Like, don't talk, and, I've always hypothesized, because I was just getting into the good part and she's stopping me. And when I reflect on her stopping me, part of it, I think, is part of the privacy around her experience is that although we have a long way to go, we have come a long way. And so for her to take me back, to when she was a kid, right, in the 1930s as a Black child in Prince George County, Virginia, right, in the dynamics of what that meant. I don't know that she wanted to go back there, but I will tell you, when I look at my grandmother, and this is all, like, I can only talk to you about my grandparents when it comes to genealogy, right? Because, it's interesting when we talk about genealogy and we talk about ancestry and what we mean by that. But I will say that I know my grandmother is in me. And I say that, and I also recognize that part of her perhaps not wanting to share her story was part of the challenges that she faced. And when and there was a time when I took her into the anatomy lab. I was doing a summer program at the Medical College of Virginia, and I just went up in the anatomy lab with my grandmother. And I think I went in there because had her circumstances been differently, she could have been the first doctor in our family, right? And so because she had all the smarts, the talent, the determination, all of that to do it. And so I will just say, and even with the constraints, right? We like to talk about resilience a lot in these public health spaces, which is important, right? Because encounters the deficit frame and everything is right. But and I want to lift that up too, because I also think she was amazing in the things that she did and but that she might not have always seen value in. Right. And so I can just and so when I reflect on my roots and my ancestry and what's in me, right? I think about my grandmother and I think about my grandfather and I think about their parents, right? Like my grandmother King, shoot, I'm gonna have to. So my mother would be wrote to. So this is my great grandmother. And I need to know the president because if I knew which president was, the story would be better. But the kids, the Black kids didn't have a school bus. So she wrote to the president at the time and said, we need a school bus in Prince George County for the Black kids. And so a school bus did arrive. It was the most broken down school bus.
But a bus.
But a bus did arrive. But you see, but wrote. It was like, look, y'all, this is a problem.
She took action.
Yeah. And so those women are in my right, like are in my DNA as well as in my spirit and soul and with me as I move in this role.
And so, how do you merge your study of history, your study of African history, and the personal narrative of your family and of your life? How do those things integrate in your vision of today? But also in your sense of the world that I believe you see yourself as one of the authors of. I think that you are a person who, with intention, is making decisions that are not just for today or tomorrow, but they're for today and also for a long time out. They're principled, ethical, and root decisions. That's my way of thinking anyway. Does that sound right to you? How does your history study and the personal narrative, how do those things merge to again direct you?
All right. I think that a couple of things that I will say is that we have to be a student of history to understand our present, right? And so when I go in and talk to people about health equity or racial inequities and disparities, I say you will never understand them if you don't study American history, right? And there's things that like I'm still learning, but like you will not understand it unless you study American history. And so I think we're just talking about the data, right? And the limitations of the data. And I just got off a call about structural racism and how we can model history. And I was, again, multiple books, so was in and out. And so I got to go back and see what they say. but I think that is essential. And I think the other thing about history is that it is a reminder. It is, or even thinking about your personal, your family, right? It is a reminder. When it gets tough, when things get frustrating, when you feel like you're knocking your head, you bang your head against the wall, where you're frustrated. If you're like me, you just want to win the Powerball and run away sometimes, right? Like, if and speaking of genealogy and ancestors, right? The fight continues, but and the fight is still hard, but it has been harder.
Mm-hmm. Yep.
And
yeah.
people persevered.
Mm-hmm.
It has been hard, and so I think I think about that. I was thinking about that. I was thinking about that just yesterday, right? Actually, because I was just thinking about I was thinking about the civil rights movement and the struggle for racial justice in the country, and I was thinking about how we're still in a struggle, right? Of course, Buffalo, New York, repeatedly seeing that happen is frightening, right? And at the same time, me going to meetings, right, is nothing like the circumstances of the people who have gone before me in the fight. And so I can fight, right, in a meeting, right? Like, come on now, right? And so I do try to reframe for myself sometimes, right? When I might get a little frustrated, or when things are not moving fast enough for me. And then I think the other thing about history is just thinking about the lessons, right? And I think, I'm not a political scientist now that I'm in the space of policy and politics. And so that's probably a space of reading and growth that I can do around sort of that strategy as you really, because it's one thing to have the data, as I was saying before, and to know and to hear and be in partnership with community about what the next best step is. It's another thing to get that next step embraced, funded. And so, I think that's a space of growth for me in this position.
I'm Al McFarlane. This has been a wonderful conversation with Dr. Brooke Cunningham. She's Assistant Commissioner at Minnesota Department of Health, a physician, general internist, also a sociologist, and she studied history as well. And what was the other degree? History
African
and
American Studies.
African American Studies. We're talking about that. And directs the bureau at the Minnesota Department of Health that is responsible for, it's called the Health Equity Bureau, a new arena of activity created in 2022, I believe, by Commissioner Jan Malcolm. And as an assistant commissioner, she's responsible for overseeing the Center for Health Equity, the Office of American Indian Health, the COVID-19 Health Equity Team, and Diversity, Equity, and Inclusion at the Minnesota Department of Health. And she also works closely with leaders and staff and other MDH bureaus to advance health equity in their work. This has been a great conversation, Doctor. I'm so happy to have this time with you. I want to invite you back anytime, or even to direct people in your team, and to the degree that you can use or work with or exploit this platform for the benefit of our state, of our residents, and the work at the department, I invite you to come back and to work with us. I want to disclose in the spirit of transparency that my company, McFarlane Media, and our newspaper, Inside News, are among the contractors that do business with the health department. All of us, I think most of us in this state, rallied at the call of the state when the COVID pandemic broke out, and the state invited us to send in proposals of what we could do to help energize, mobilize, create awareness about COVID-19 interventions, mitigations, protocols, so that people would be less victimized by it, and so that the state could do its role in trying to keep down the number of infections, the number of hospitalizations, the number of deaths. And we're at a place now where we, as a community, feel we've come through the major round of COVID-19, but now with Omicron and the variants that follow, I think it's wise to ask people to not let their guard down, to retain some of the protocols that they may have developed in response to the massive presence and massive rate of infection that we experienced a year ago, that we've sort of had some success with. What do you think? We've got about 3 minutes or 4 minutes to finish up here, but I want to ask you, what should our listeners and our communities and families do in this era where, as I drive around town, I see gazillions of people out shoulder to shoulder, like it never happened, and I'm scared to death. I still mask everywhere, and I'm not doing meetings in person. I've done maybe 3 meetings in person in the past 2 years, and I'm okay with not doing that. And I don't want to be over paranoid, but I want to stay alive. That's number one. And so, what do you tell people? How do we get people to stay aware and to take the shots if they are available, the boosters if they need them, and also to keep doing the protocols? What do you think?
Right. No, thank you for giving me a little bit of time to speak to COVID-19. That's a big part of my role in the last several weeks that I've been at MDH. And I know people so desperately want to get away from always wearing a mask, to get back to being social, right? We're not used to masking, and we like to be in relationship. We're social beings. And at the same time, what we're seeing right now with the new variants is that the numbers are creeping up, right? They're creeping up. They're creeping up in communities of color, among American Indians. We haven't seen the same increases in hospitalizations, but those two, right? We could expect with more cases, right? May creep up. And so this is what I would say as somebody who is a physician, right? And who now is in a public health role. If you come into my office, I'm looking at your COVID vaccine record, and I'm asking you, and I'm looking, have you been boosted? And for those of you over 50 or immunocompromised, I'm looking whether you've been boosted twice. And I am imploring folk to go complete their vaccination series and to get boosted. I know people have had concerns about the vaccine. At this point, I think in Minnesota, like 9 million doses, that's in Minnesota, of the vaccine have been administered. We're not seeing, right, as the scientists predicted, you get a sore arm, you might be tired, right? You got to work it around your work, which is a thing that MDH is trying to provide other sort of opportunities outside of regular healthcare for you to get vaccinated. But the vaccination has prevented the worst outcomes, right? And we want people on this side of dirt, right? And so I really do still very much encourage people to complete their vaccination, get boosted, get double boosted if you're eligible. And we're going to expect probably to continue to see boosts or new vaccinations that are tailored to the variants as we go forward. So COVID is not leaving us. We want it to go away, but it's not leaving us, and it can still be deadly.
And so I'm speaking now from a member of the Black community, as the sense of COVID, waning appears. How do we make sure that we don't fall victim to becoming too lax? I mean, that's where data comes in from my point of view. I think in a call I asked you, how do organizations like this radio show or my newspaper or podcast get access to enough data consistently, and what can and how should we be able to keep the awareness needle high, so that people don't think out of sight, out of mind, I'm okay.
Right. I think there are two things, Mr. McFarlane, and I know you know this too. Like, there is for MDH, if people are interested, if you go into our website, there's a COVID weekly report where you can track things like the cases, the hospitalizations, even the sort of mortality rate around COVID. But the other thing, as you know, as a person in media, right, people's personal stories are incredibly important. And I think we have to do a combination of both. We have to make the data case, make the science case, speak to concerns. When I look at the data, for example, we've had the 5 to 11 vaccine out since the fall. Only about 23, I was sharing this with you in that meeting, about 23% of Black kids between the ages of 5 to 11 have completed their vaccination series. Okay. And that may be because parents have some concerns about the vaccine, perhaps in their youngest.
Compared to the general population, what's the number?
So in the general population, if I think about African-American adults,
I mean, among kids 5 to 11, what's maybe you don't have the numbers.
I'd have to pull that, Mr. McFarlane. I don't want to misspeak here, but I know the range goes up to, I think, in our most highly vaccinated kids to about 55%. And I believe that's in the Asian population. So there's a range. And so there's opportunity across all groups, but there are opportunities for kids. There are opportunities for young adults in the Black community, right? And then I think we also have to think about the folk who are around us, right? So I spoke about my grandmother, who's no longer, with us, but think about who's around you and who might be more vulnerable than you are. I have a daughter who is 3.5. So I think about, she's under 4, she don't have a vaccine. Right. And so I think about her too. Also think about your own exposure. A lot of, part of the COVID mortality disparities is that people of color often work as essential workers. If you have lots of exposure to the public in your work, right, where people are going to now walk around without masks, protect yourself, right, so that you can protect your family and continue to care for them. So that's what I don't know if I answered your last question, but of course I'm saying as Dr. and Assistant Commissioner of Health Equity, please go get vaccinated and boosted if you haven't already.
That's a great way to end the show, Dr. Brooke Cunningham, Assistant Commissioner, Minnesota Department of Health. Dr. Brooke, thank you so very, very much. My offer is open. Let's collaborate and use our platforms as one of the methods for connecting and building the engagement you're looking for. I'm Al McFarlane. We'll see you next time. Take care. Bye-bye.
Thank you. Bye-bye.